Welcome everyone to the SAB's July educational webinar event, Persistent Air Leak Bronchopleural Fistula. Before we get started, just a few reminders to anyone new to the SAB webinar platform. You all have joined in a listen-only mode. Please submit all your questions using the question feature that is located on your control panel. We will address all the questions after the lecture and during the Q&A portion. At this time, I'll hand it off to Dr. Hussam Naif, who will be moderating tonight's session. Dr. Naif is the chair of the Education and Program Committee here at the SAB and sits on our Industry Relations Committee as well. Hussam?
Oh, thank you, Emily. Welcome again, everyone, to our educational webinar at Society of Advanced Bronchoscopy. Your host today is Hussam Naif. We present to you monthly discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today, we have an exciting topic talking about persistent air leak and bronchopleural fistula by Dr. Reza Ronaghi. I have the honor today to present to you Dr. Ronaghi, who is a colleague at Society of Advanced Bronchoscopy Industry and Relations Committee. Dr. Ronaghi is well known in the field of interventional pulmonology. He is currently an interventional pulmonologist faculty member at UCLA, where he did his interventional pulmonology training. He trained for pulmonary critical care at University of Southern California, and his area of expertise are pleural disease and pneumonitis, especially drug-induced pneumonitis. Without further ado, Dr. Ronaghi.
Perfect. Thank you so much, everybody, and thank you for joining the webinar. It is a pleasure to be here and to talk to you guys about a topic that I think is a topic of not only interest, but a topic that always creates a good discussion amongst everybody. Okay, without, we'll go ahead and get started. And like Hussam said, I am one of the IP faculty at UCLA, and I'm going to be talking about bronchopleural fistula, also synonymous for alveolar pleural fistula, and I really do view them as the same disease. And so, just a quick disclosures, I don't have any disclosures. And obviously everything in this presentation is going to be very data driven, as well as my own experience dealing with alveolar and bronchopleural fistula. So really, what we're going to divide our time going into is, going obviously through some definitions, going through some of the causes and risk factors for developing bronchopleural and alveolar pleural fistula, going through the evaluation process and grading, and try to focus a lot of our time on the treatment options. I know a lot of us already know the first three, how to diagnose it, how to evaluate it, but the treatment is where, it gets a little bit tricky and some of the interesting discussions come up. Before we begin, I'd like to just present a case that we dealt with not too long ago. So here's a gentleman, past medical history of COPD, obesity, who had a right upper lobe lung adenocarcinoma, status post the right upper lobectomy, as well as some mediastinal dissection, did well, got discharged from the hospital, no complications, who then presents back to the hospital about a month later with a pleural effusion and found to have an empyema, a chest tube was placed, found to have a continuous leak, and underwent a bronchoscopy. When the patient underwent a bronchoscopy, this is the visualization, and actually on further going into that right upper lobe opening, this is what you saw. You actually saw the pleural chest tube that was placed in the patient via the bronchoscope. So hopefully this lecture will give us an opportunity to see how would we manage this patient, what are the options, and what different treatment modalities do we have. So quickly, let's begin with a definition. So what is, again, alveolar or bronchopleural fistula? It's a connection between the main stem lobar or segmental bronchus or the alveolus and the pleural space. Now, for the sake of this discussion, when I say bronchopleural fistula, it also does include alveolar pleural fistula as well. So they are, again, very synonyms when I'm discussing about BP fistula. So what are some of the causes of bronchopleural fistula? It is usually very commonly encountered after lung resection surgery. This could be after a lobectomy, segmentectomy, or pneumonectomy. It could be seen after mechanical ventilation. Patients may have lung disease, pneumonias. Mechanical ventilation can lead to pneumothoraxes and then subsequently BP fistula. Malignancy is a risk factor for developing BP fistula, especially the treatment of the malignancy. So radiation and ablative therapies are risk factors for developing pneumothorax as well as BP fistula. Obviously, traumas, penetrating traumas, pulmonary infections, a lot of TB and fungal infections, cavitary lesions do extend into the pleural space, hence causing continuous BP fistula and leakage into the pleural space. And then obviously there's a lot of spontaneous causes, spontaneous pneumothoraxes, especially in patients who may have underlying lung disease that may lead to continuous BP fistulas. Here's just one paper by Lois and his group looking at the different etiologies of bronchopleural fistulas, some of the infectious etiologies very common in Aspergillus, some of the atypical infections like Haemophilus, Klebsiella. GI causes, mainly you're going to be looking at patients with gastroesophageal reflux disease, with Barrett's esophagus, or Boerhaave syndrome in patients who may have increase in intrathoracic pressure, leading to, again, that lung collapse and bronchopleural fistula. Malignancies, mainly it comes again from the treatment of that malignancy, but esophageal cancer is one that can erode and cause bronchopleural fistulas. Thoracic traumas, necrotizing lung diseases, again, it could be from radiation, ARDS, and obviously idiopathic reasons. Now, like we said, post-surgery is some of the most common causes of seeing bronchopleural fistulas. And so the incidence really mainly was seen with lung volume reduction surgery, and the incidence was pretty high, as close to almost 50% in certain patients. Pneumonectomy also does have a high risk factors. It's been reporting in various different studies anywhere between 5 to 20%. Lobectomy, obviously much lower, but still can present in 0.5 to 1%. And from transbronchial biopsies and mechanical ventilation and spontaneous, the incidence is really unknown at this time. So risk factors for developing bronchopleural fistula post-surgery, these are just some of the common risk factors that can lead to delayed healing, more lung damage, and subsequently bronchopleural fistula. They include diabetes, patients who may have a heavy smoking history, or COPD, poor nutritional status, a residual tumor at the bronchial margin, a large diameter of bronchial stump post-resection, extensive lymph node dissection, patients who are older, prolonged postoperative mechanical ventilation, as well as closing technique, which we'll talk about in a slide or two. So as you can see on our original patient that I presented, he does meet multiple of these. He was older in age. He had extensive node dissection, as well as a large diameter bronchial stump. So all of these things, as well as a previous smoking history, put him at risk of having bronchopleural fistula. Again, in a paper by Wright and his colleagues, they looked at the risk factors for bronchopleural fistula in surgical patients. They found that postoperative ventilation was the highest rate of bronchopleural fistula, as high as 19%. Right pneumonectomy tended to also have a higher risk, and that was statistically significant, close to 6%. Pleuropulmonary infection preoperatively had a risk factor of 8%. Radiation also did increase that risk, however, it was not statistically significant. And completion pneumonectomy, again, does have a possible risk factor, but both of those last two were not statistically significant. Now, what about closure techniques? And there's been a lot of actually different reports, a lot of old studies, because again, the method of closure now is very standardized amongst centers. However, previously stapled closure was a very common method used, and there was a higher risk of bronchopleural fistula in stapled closure methods. And so here's a few papers originally from the late 80s, early 90s, looking at stapled methods of closure, and they found that bronchopleural fistula rates were anywhere between 5 to 7%, so a pretty good one. Complete tracheal closure was 0%, continuous suture pretty low at 1.5, and interrupted suture at 3.1. And in myself, having checked with a lot of our thoracic surgeons, they are pretty much all either tracheal or continuous sutures, and hence the risk overall of bronchopleural fistula from closure technique is pretty much non-existent or extremely low at this time. Now, what are some of the risk factors for patients developing bronchopleural fistula if they had a spontaneous pneumothorax? Major risk is those who may have underlying lung disease. So, patients who have COPD, cystic lung disease, these patients who may have a pneumothorax have a higher risk of developing a bronchopleural fistula and not healing, obviously because of that underlying lung disease. Patients who may have large bullous disease as well as increase in age are also risk factors for developing spontaneous pneumothorax. Again, another paper by Okuda and his colleagues looking at the risk factors of bronchopleural fistula after thoracic surgery. This was a large review article looking at the risk factors of various different thoracic surgeries. Now, when they did a multivariate analysis of all cases of bronchopleural fistulas and all different types of surgeries, what they found is that history of malignancy was statistically significant with a high odds ratio of developing bronchopleural fistula. They also found that a right lower lobe location also was statistically significant, having an increased risk of developing bronchopleural fistula, and then complete or pneumonectomy had a higher risk, and again that was almost an odds ratio of 24 and statistically significant for developing bronchopleural fistula. So the three big risk factors for surgery is history of malignancy, right lower lobe, and complete pneumonectomy all had increase in risk of developing bronchopleural fistula. But then they subsequently divided it into those who got lobectomy as opposed to those who got pneumonectomies to see if it really made a difference. And the only main thing when they looked at lobectomy, the only two significant kind of things that led to bronchopleural fistula, one was malignancy, which was almost nearing statistical significance at 0.056. Again, history of malignancy. The second two components was right lower lobe location and a history of neoadjuvant chemotherapy. So for lobectomy, history of malignancy, chemotherapy, and a right lower lobe location increase the likelihood of developing bronchopleural fistula. And for those with complete pneumonectomy, history of hypertension, right side, and complete pneumonectomy all had an increased risk, a high odds ratio of developing bronchopleural fistula post-surgery. Now, once we have identified that the patient does have a BP fistula, how do we grade these systems? And there are a couple of different methods of grading these systems. The most common way is the Cerfolio classification air leak, which is graded in a 1 to 4 fashion. Grade 1 is during forced expiration only. So this is usually when you tell the patient cough and you'll see a few bubbles come. Grade 2 is with expiration. This is not forced expiration, but any form of expiration leads to an air leak. Grade 3 is on inspiration, you see an air leak, and grade 4 is continuous bubbling in all chambers during both inspiration and expiration. Just for our mainly knowledge, there is also the Sang classification technique, and this is kind of very similar in that it goes in a 0 to 4 instead of a 1 to 4, 0 being that no air bubble is seen. Grade 1 is 1 air bubble at the 3 volation, it's based on cough. 2 is persistent air bubbles with the patient coughing. 3, persistent but very small amount of air bubbles on spontaneous respiration. And grade 4 is a large amount of air leak on spontaneous respiration. There are also some digital devices, and just again for us to know, these devices are, I think, super interesting in that they actually are able to put the flow rate, so you can actually know how much of a leak there is into that pleural space. And so they are digital, they are attached to your chest tube, and they actually will display what is the flow. And so here you see in this picture, it will say, for example, 0 mLs per minute, and it actually can chart it out over a 12 or 24-hour period where you can see, is it with inspiration, with expiration throughout the breath cycles, is it with coughing only, as well as obviously allows you to know how much pressure the patient is on or if they're on water seal or not. So a very cool device in case you do see it and you have the luxury of having this in your hospital. Obviously that's really nice, but a lot of hospitals I know don't have that, and so we're just left with the chest tube meter. This is what you typically see on your Pleurovac. It could be a dry or a wet Pleurovac. You see these numbers at the bottom, usually graded on a 1 to 5 or a 1 to 7, just depending on the various different brands. And this is talking about the amount of leak that you see, with the lowest starting at 1 and highest going all the way to 7 along the various respiratory cycles. And so all the classifications, you'll usually ask the patient, to take a deep breath or to cough, and you want to see how much of a leak there is. If there's only a couple bubbles coming out at column 1, well, that's a very small leak. Perhaps you are heading towards the BP fistula healing itself, whereas if you have a grade 7 leak throughout the respiratory cycle, that's a very large bronchopleural fistula, one that is unlikely to heal. So again, what are clinical features of bronchopleural fistula? Now again, the bronchopleural fistula in itself is not going to have very specific clinical features. Originally, obviously, the patient is going to come with pneumothorax symptoms. So they're going to come with chest pressure, sometimes maybe tension physiology. They'll have shortness of breath. So the symptoms are typically one of a pneumothorax. Now, in patients who may have a small leak slowly, they can also present with signs of a pleural effusion or an empyema. So that's usually the original presentation. Once a chest tube is placed and you've evacuated the fluid or the purulent material or the air, there's very little symptoms at that point, minus obviously symptoms of the chest tube. So now what you're mainly looking at is a continuous air leak, like we've already described, or on clamping trial or on taking the patient off of suction, symptoms of a pneumothorax arising again. So as you clamp it, air accumulates, and subsequently you can develop the symptoms of shortness of breath, chest pain, hemodynamic instability if there are signs of tension pneumothorax. One other thing to notice is these patients can also develop subcutaneous emphysema, especially if you have a small chest tube in place. And usually if there's a high enough pressure in the pleural space, it obviously wants to take the path of least resistance, that is through the tube. However, if the amount of air produced in the pleural space is not able to be kept up with the size of the tube that you have, or it's not on a high amount of suction, it usually tries to find a path of least resistance. And that path can be around your chest tube and into the subcutaneous tissue, leading to subcutaneous emphysema. Now, once you cleared, diagnosed that the patient does have a pneumothorax, and you've cleared the patient, put a chest tube in, obviously make sure they're not in tension, what is the evaluation to determine that the patient does have a bronchopleural fistula? So first and foremost sign, once the chest tube is in place, again, you will see that continuous leak. That is the first clinical presentation that you will identify someone having a bronchopleural fistula. They will have some form of a leak at varying different points of the respiratory cycle or throughout. The next step is to consider imaging. We always obviously start with a chest x-ray. Now, if you have full dehiscence or stump dehiscence, that is possibly something you may be able to visualize on chest x-ray. However, in general, most bronchopleural fistulas are not going to have any distinct features on chest x-ray, minus showing the pneumothorax originally or the pleural effusion, and then subsequently the chest tube being in place. Now, we will always get a CT scan. In general, it is very hard to identify the broncho or alveolar pleural fistula on CT scan. You are looking for a tiny area of damage where there is this continuous leak. But it is a good place to start, because if you identify it, just like in these two images, so you can see that there is a on the picture in the right side, there is a bronchopleural fistula on the right main stem bronchus, as well as here you see an alveolar pleural fistula on the picture to the left. If you're lucky enough to be able to identify that, it does make the management much easier. You can identify the segment that is damaged, and it allows you to have better treatment options for the patient. So again, a CT scan is a good place to start. However, if you do a CT scan and you're not able to identify that area of damage, it is not discouraging, and it is not an abnormal finding if you can't see the abnormality on CT scan. The next, usually what you want to do is bronchoscopy. Now, bronchoscopy should always be the next step after chest x-ray as well as a CT scan, because one, you want to take a look inside to see if there's any visual damage that could potentially be leading to the broncho or alveolar pleural fistula. So if they've had surgery, has there been dehiscence? Has there been trauma to the trachea, to the bronchus, to the secondary tertiary bronchuses, to the point that you can identify the area of the lesion? If you're lucky enough to be able to identify it, it also gives you the chances of possibly doing a therapeutic session during that time. However, if you cannot identify the location based on just inspection bronchoscopy, you have two other options to identify where the damage may be coming from. First and foremost is balloon occlusion. And so here on the left, you see a Fogarty balloon inserted into an airway. And so how this typically will work is the patient will be either under general or spontaneous ventilation. The bronchoscope goes in with the Fogarty balloon, and you start with occluding each of the segments of the area you think may be involved. And during that 3 to 5 respiratory cycles, you're looking for the leak on the chest tube meter to go from a leak being present to no leak being present. And so generally what you'll want to do is start at a much larger segment and slowly try to narrow your way down. And so an easy way to think about this, you want to start maybe with occluding the right or left main stem. Now, hopefully that's not a question. Next, you want to consider maybe right upper lobe. Block the entire right upper lobe and see if that blocks the leak. If it does, now you want to go into each of the segments, start with the apical, the posterior, the anterior, to see if there's one segment that's involved or are all of them involved, and it will help you with treatment-wise. So the balloon occlusion method is one that can help identify the leak. Now, it is not always as easy as that, especially on patients with positive pressure ventilation. It can be a challenge to truly identify, but this is another reason to consider doing bronchoscopy. And finally, last but not least, is dye injection. So you can actually inject dye through the chest tube into the pleural space, give it some time, and hopefully you're able to visualize the dye on the bronchoscope, identifying where that dye is coming from. So you'll inject it into the pleural space, give it some time, and if you now all of a sudden see that dye come from the right upper lobe, you know where that damage is, and again will allow you to help. And so here on the picture on the right, you see methylene blue injected into the pleural space, and you're able to see it come from which segment and subsequently be able to treat it. Now, just one thing that I would like to is a little different, and so it's important to know of this condition so we don't mix it up with bronchopleural fistula. This is known as benign emptying post-pneumonectomy space syndrome. This can mimic bronchopleural fistula, however, it is just treated with conservative management. So this is usually patients who are asymptomatic. They usually don't have much fever. They will have fluid accumulation in that space post-pneumonectomy. They have negative culture. And when you do bronchoscopy, you don't actually see a continuous leak or damage on ventilation scintigraphy or able to identify an area with a continuous leak. It usually happens in about 6 months or up to 6 months post-surgery. And the idea here is that it's post-operative intrapleural pressure shifts that promote the exiting of that pleural fluid into that space and can fill it up, and you can have some air leak in that. So when you put a chest tube, you may see some continuous air leak. This is usually just managed with chest tube drainage and conservative management, and usually does heal by itself. So this is not a bronchopleural fistula post-pneumonectomy. Now, the majority of our time, let's focus on management, because I think this is the big area of interest for a majority of people. First and foremost, I'll start with saying, a lot of the consensus guidelines or data, there isn't much about it. The ACCP has a guideline from 2001 that I'm pretty sure none of us use. In 2001, almost 22 years ago, their idea was that we should do observation for spontaneous closure for 4 days post-surgery, and if it doesn't heal after 4 days, is to consider early surgical evaluation for pleurodesis via VATS after the initial 4 days. They actually advised against chest tube or bronchoscopy and advised against chemical pleurodesis via chest tube. And so that was the recommendation back then. Again, I don't think we use these guidelines, but I just want to show that there hasn't really been any updated guidelines when it comes to persistent air leak management. The BTS does also have a similar guideline in 2010 advising against bronchoscopy and early surgical consultation within 3 to 5 days of developing bronchopleural fistula. So again, not that many great data out there or great guidelines. So again, it is very dependent on center to center, clinician to clinician, level of expertise at the facility. I just want to quickly go through this chart because I think it's very summarizes what we will be talking about in the next few slides. So if you do have a persistent air leak after 5 days, is it a spontaneous pneumothorax or not? If it is, and the patient is a candidate for surgery, the patient should undergo surgical management. If it's not a spontaneous pneumothorax, then you want to put a chest tube. If there's an infection, treat the infection, make sure they have good nutritional status, minimize positive pressure. If those things help, then great. You want to continue that and see if they can have conservative management with healing of the bronchopleural fistula, and if they do, chest tube can come out. However, if those things don't reduce the air leak, then next is to consider identifying the location of the leak, and that's done via both CT scan and bronchoscope, looking for fissure completeness. If you do have fissure completeness and you're able to identify where the leak is coming from, at that point, you want to consider bronchoscopy with endobronchial valves. If they are not able to identify, or the fissure completeness is not a case, then you want to consider them for surgery if they are surgical candidates. And if not, you want to consider pleural interventions such as pleurodesis, blood patch, and so forth. So I think this is just a very quick summary on how we treat patients with persistent air leak that doesn't go away after the first few days post chest tube placement. But now we will try to kind of go into these various options in detail so you can see the pros and cons of each of these treatment options. In general, it is important to note that majority of the cases will require some form of an intervention. So with chest tube drainage and hoping that the bronchopleural fistula heals is very rare. So about 80% of patients will require some form of intervention after the first couple days. Most bronchopleural fistulas early in the post-operative period should go early surgical repair, and that has excellent success. So if you're early post-op, you still have a leak, undergo surgical repair, and that's the best option. However, for patients who are not surgical candidates, patients who may need it as a bridge to surgical candidates, patients who may have septic shock or severe respiratory compromise, those patients should undergo these other modalities that we are going to talk about. Some of the management options that you have for a bronchopleural fistula is prolonged chest tube with drainage, considering placing a Heimlich valve and discharging the patient home and seeing if it will heal over time. Pleurodesis. Pleurodesis can be done via chemical pleurodesis or blood patch pleurodesis, surgical options, and bronchoscopic techniques. Now, first and foremost is on patients who is supportive care, and that supportive care is important in the overall outcome of the patient. Now, if the patient does have respiratory compromise and is on the vent and is mechanically ventilated, the first and foremost should be weaning from the vent or vent management. That is done with daily SPTs and wean the machine as soon as possible. If that's not possible, decreasing the positive pressure that the patient is on will hopefully allow the lung to have more time to heal. Decreasing the tidal volume will again give the lung hopefully more time to heal, and decreasing the inspiratory time. So again, all of these, if you notice, the focus is on giving the lung some time to heal from the bronchopleural fistula. Other supportive cares is if you have chest tube management, is to consider minimizing suction. And this is a area of I think controversy, and I'm talking both with my colleagues and even with some other thoracic. The idea is that if you have your suction on high, there will be a continuous leak of air through that damage into the pleural space. However, if you minimize suction, you give that lung some time to heal that damaged area. And so minimizing suction is considered to be helpful in treatment of bronchopleural fistula. If there are signs of infection, obviously treat the infection appropriately. Improving nutritional status, and as we described, ventilator settings is super important. So for the ones that are post-surgery, early on, surgical methods is the best option. For post-operative patients who either failed conservative therapy or are high risk for surgery or as a bridge to surgery, bronchoscopic management is appropriate. or for bronchopleural fistula for other reasons other than surgeries or lung resection, bronchoscopic methods are used. So again, if you've had surgery and you have bronchopleural fistula early on, surgical treatment is the option of choice. However, for other reasons of bronchopleural fistula that we described earlier, bronchoscopic methods are the method of choice, or if the patient is too high risk to undergo surgery again, or as a bridge, bronchoscopic methods are used. So what bronchoscopic methods do we have? And really this comes down to the size of the fistula. So if you have a large fistula, these are usually seen in the trachea in the primary to secondary bronchuses, and that measures above 8 millimeters. We usually consider that a large fistula. The options in these cases include stents, coil, and Platzner devices to treat and close that large bronchopleural fistula. So let's talk about each of these a little. Stents. There's been multiple case reports suggesting the use of silicone or covered metallic stents for bronchopleural fistula. And again, the idea is that if you can identify where the damage is, you can cover that space with a stent and give it time to heal. And so here's just one case report of a bronchopleural fistula that had a right Dumont silicone stent placed, and that stent led to covering of that fistula location and giving it some time to heal. Now, if you remember our case from the beginning, the gentleman had a right upper lobectomy with dehiscence to the point that our bronchoscope can get into the pleural space and view the chest tube. So our patient also underwent a silicone stent placed into the right main stem, covering that stump, the right upper lobe stump, and just opening straight into the bronchus intermedius. That stent stayed in for a good 6 weeks and was exchanged out, and subsequently actually the patient had healing of that stump and had closure just by granulation tissue, and over time had healing, and the stent was able to be removed many months later, but it did have that healing effect. So for large areas that you can see, large fistulas, stents, both metallic and silicone covered stents, are good options with good healing response. Now, what about coils? There have been a few case reports of using angiographic coils, either alone or in combination with other occlusive material to treat bronchopleural fistula. And so here was one case report. You can see bronchoscopically, coils were placed into the fistula location, as well as giving it some time, and the fistula heals itself. Now, what about Platzner devices? I know there's been a few people that may even be on this talk who've used Platzner devices to help close large fistulas. Now, just to review, Platzner devices are typically designed for atrial septal defects or patent foramen ovales, or as vascular plugs. So they are not marketed and used for this. However, there has been a lot of case reports and even a case series that we're going to talk about using Platzner devices to close large bronchopleural fistulas. And so the idea here is, again, these plugs are made for an atrial septal or vascular defects, but if you see a large defect in the airway, you can use this as a plug to completely close off that fistula and that location. And in the largest case series that at least I can find by Battistoni, he looked at 31 patients with large fistulas that underwent Platzner devices, and they found that this was effective in 96 patients, 96% of patients, which is great. They followed the patients up for a total of 17 months, and they were able to see that the Platzner devices still were effective in those patients who were alive at 17 months. So 30 of the 31 patients had healing of the bronchopleural fistula, making it a 96% success rate. Now, again, 45% were still alive at 17 months. However, all the deaths were actually not related due to bronchopleural fistula recurrence or pneumothorax recurrence or complications from the Platzner device. A lot of them was because of malignancies and various other causes. So all patients that they were able to follow up, they never had a recurrence of the 30 of the 31 never had recurrence of the bronchopleural fistula, and the cause of death was something other than the bronchopleural fistula or these devices. So it is a great device. If you do see a large defect, there has been great success rate with using Platzner devices. Now, what about for smaller fistulas that can be visually seen or may not fully be able to be visualized? Let's talk about these. So first and foremost, you can consider occlusive material. So there is a lot of different occlusive materials out there, such as fiber and glue and some other material that you can actually be able to inject into that space and lead to the healing of the bronchopleural fistula. And so here's one study from 2000 through 2001, where they looked at 38 patients, and these patients had all undergone some form of resection surgery, so thoracic surgery. And in these 39 operations, 38 of these patients were able to undergo this fiber and glue material used to treat the bronchopleural fistula, and they were able to get most of the bronchopleural fistulas healed and able to get the chest tube removed with an average of 3 days. And so very good outcome post-surgery of using this glue material. So here's, again, I'm sure most of you guys have seen this, various different reasons to use the fiber and glue, but one option is to use adhesive material if you can visualize where that fistula is. And so here's a pictorial representation of a fistula that is that fiber and glue is used to heal or block that opening. What about heat therapy? And so APC or YAG laser has been used in patients with small bronchopleural fistulas to help with closure. So here's one case study looking at a patient who had undergone a sleeve pneumonectomy and subsequently ended up developing a fistula after some time, came back to the hospital with a pneumothorax, had a chest tube placed, found to have a bronchopleural fistula. They underwent a bronchoscopy under moderate sedation, and they were able to see a small opening from the surgical stump site. And they were able to actually use heat therapy, in this case APC, to cauterize as well as create some both char and granulation tissue over that small defect, and able to get the chest tube ultimately out and fix the bronchopleural fistula. Again, obviously this is just a picture from using APC and heat therapy in the airway. Now, what about chemical pleurodesis? We do commonly deploy chemical pleurodesis in patients who are not surgical candidates or possibly not candidates for valve therapy. It can be done via chest tube or via thoracoscopy. The idea here, obviously with all pleurodesis, including for effusion, is that it leads to an inflammatory response that leads to scar obliterating the pleural space and allowing that pleural defect hopefully to heal. The various agents that can be used, obviously talc, iodine, doxycycline being the most common one, and tetracycline and minocycline kind of historically have also been used. With chemical pleurodesis, as always, the main thing, especially in benign diseases, is the patients may have pain, but there's always the risk of ARDS, fevers, and infection that should be described to the patient, hence why having strong pain medication on board is important. Here's one paper by Howe and colleagues looking at chemical pleurodesis for prolonged postoperatively in primary spontaneous pneumothorax. This was 1,000 patients that underwent that, and of those, 79 had prolonged air leak requiring pleurodesis. They got pleurodesed via 2 different agents. One is the OK432, which is very similar to bleomycin, and minocycline. 19 patients underwent this bleomycin-like material with a 95% success rate. 60 patients underwent minocycline. 63% had success, not only in pleurodesis, but success in healing of the persistent air leak. 37% had failure. Of those 37%, 10 underwent bleomycin-like material with 90% success, and 12 underwent repeat minocycline with pretty much 100% failure rate of that second minocycline agent. And so overall, it's to show that chemical pleurodesis does have a good success in treatment of prolonged air leaks. However, your agent of choice is really important. As you can see here, bleomycin-like material much more effective than minocycline. But overall, a good option. These days, we mainly use iodine and talc. There has been no study looking at these agents in persistent air leak per se, but we both know, and we all know, that both agents are very effective in causing pleurodesis in other causes like pleural effusions and malignant pleural effusions. So agent of choice is really good, but overall a very good choice in treating patients with persistent air leak. Now here, when they looked at the two groups, the minocycline and again the bleomycin-like group, 60 were in the minocycline group, 19 in the bleomycin group. They both requested pain meds. However, the dosage of pain requirement with minocycline was much higher. Complications was about the same, slightly more percentage-wise in the bleomycin, but they both had complications including effusions and fever. However, success with primary treatment, you can see with the bleomycin was almost 95% as opposed to 63% in the minocycline group. And so again, a good option with good success rate. However, agent of choice is extremely important. Now, what about blood patch? Blood patch, autologous blood patch pleurodesis is used when you can have complete lung re-expansion. So what is blood patch? It's taking the patient's own blood and injecting it through the chest tube or through a thoracoscopic method into that pleural space. The idea here is that you have blood wants to coagulate pretty quickly. You can hopefully have a nice covering and coating of the lung, and as that blood kind of hardens and becomes more clot material, it will hopefully cover the area of damage of the alveolar bronchopleural fistula, leading to healing of that fistula. It was first described and used in 1987. It is very safe and well tolerated because it is the patient's own blood. It has been reported to have success rates as high as 90%. However, the key caveat here is it may need to be repeated several times before reaching that success. So if you do it once and you don't get the success that you want, continuing on with a second or third time is important. It's usually 100 mLs of blood that is instilled via chest tube and 20 mLs of saline into that chest tube and into the pleural space. After that, what you want to do is place the chest tube above the level of the lung, because if there's air, you want that air to escape. However, you don't want to place it on suction, so that hopefully the blood is again able to cover that lung and kind of coagulate over that lung, covering the space of injury. Now, in one meta-analysis looking at blood patch, they found that varying different success rates, but they found overall success rate of almost 93%. So 70 to 81% treated with postoperative air leak had complete healing of the air leak at 12 hours post blood patch, 95% within 48 hours. Average of 6 days with blood patch and just simple drainage before chest tube was removed and the bronchopleural fistula was healed. And so again, overall success rate of almost near 93%. Now, in this varying different studies, reoccurrence rates were anywhere between 0 to 29%. However, interesting that in two studies, but one study, when they compared controls, which was just saline, as opposed to blood patch, the reoccurrence was 0 as opposed to 16% in the control. So really, yes, there is a potential for reoccurrence, but overall pretty small. Complication was again reported anywhere between 0 to 19%. However, if you went through and looked at some of the newer studies that have been done in the past few years to about a decade, the overall complication rate was below 8%. The main complication rate is infections. Again, blood is a very good medium, and so you want to make sure that you're doing this extremely sterilely to prevent the chance of patients developing empyemas and infections. But overall, blood patch, very safe, very well tolerated with a great overall success rate. And again, so here's one more study looking at is blood pleurodesis effective in persistent air leak. And so again, they looked at 43 papers, like I just mentioned, with an overall success rate of almost 93%. Another paper by Chow and group, they looked at intrapleural installation of blood patch for persistent air leak in patients with COPD. So these are patients that had spontaneous pneumothorax who had COPD. They had persistent air leak on day 7. They underwent various degrees of blood patch, so 0.5 mLs per kg, 2 mLs per kg, 1 ml per kg, and just control, which was just 1 ml of saline along with that. What they were able to find is, so subsequently, they made sure that there was no air leak and chest tube came out 48 hours later. What they were able to show that, again, very high success rate. However, it did depend on the size of the air leak. So on patients who had small air leaks, described as size 1, they had almost a 92% success rate. Patients with large air leaks graded as a grade 3 or a 2, they had much smaller, 50 to 70%. But even despite that, given the safety profile of blood patch, I would say I think it's a very great first option to consider, given the high success rate, especially in small leaks. Now, what about valves? So we know that there are 2 valves out there, Spiration and Zephyr, and especially the Spiration by Olympus does have FDA humanitarian use for bronchopleural fistula. It is obviously placed via the bronchoscope, and the idea is that these are one-way valves. So they are placed into different segments of the lung, and they prevent air from entering through the trachea and bronchoscope through that segment and hopefully not able to pass into the pleural space. In order for these valves to work, you do need intact fissures between the different lobes so that they can be effective. This is very similar to BLVR, except you're using it for varying different reasons. Complications of valves obviously are moving, coughing it out, infection, and respiratory failure. So the key here is being able to locate the area of the leak. And that's kind of similar to what we described earlier. That's obviously done via bronchoscope. The CT scan may help you in identifying. However, you still will need to do the bronchoscope. You will have balloon occlusion of the different segments. Again, I always start larger and try to narrow down the different segments. As you go through the different segments, what you're looking for is that as you occlude that segment, the leak on the chest tube goes away. You usually do have to give it about 4 or 5 breath cycles before the leak does go away. It is not instantaneous, as there is residual air in that segment or in that lobe that may be making its way out. If that doesn't work, you can obviously do the methylene blue or the dye method we described earlier. CT chest can help, and ventilation scintigraphy can also help as well. In the procedure, you're going to be doing the identification of the area of damage. That's done with balloon occlusion. You want to size your balloon, and then obviously the deployment. Now, the balloons do come in varying different sizes, and so you want to make sure that you have the appropriate size based on the segment you'll go. So depending on after you've identified where the area of the leak is, you will measure each of those segments to identify the size and subsequently deploy the appropriate valve into that space. Now, the spiration guidelines, if you look online, when should you consider valve therapy for people, is people who have an air leak on postoperative day number 7, status post segmentectomy, lung volume reduction, or a lobectomy. Patients who have an air leak on postoperative day number 5, and that's continuous on inspiration, or if they have respiratory failure and emphysema, you'll consider it earlier on day 5. And then typically the guidelines state that they should stay in for 6 weeks and can subsequently be removed, hopefully giving that lung time to heal, and can be given a shot to be removed after 6 weeks. Now, what does the study say? So here's a study by Yarmus and Gilbert looking at endobronchial valves in the management of chest tube drainage for air leaks. What they found is there was 112 patients with prolonged air leak on chest tube. Of those, 94 underwent bronchoscopic evaluation with balloon occlusion. 75 were candidates for valve placement. Of those, 64 were able to undergo good occlusion and valve placement. 11 had to undergo a staged approach, meaning they had to go back for secondary or tertiary procedures. But pretty much what they were able to find is that Overall success rate was very great, but the cause of bronchopleural fistula did also have a factor. So if you were iatrogenic, there was 15 patients in that group, pulmonary resection surgery, 28 patients in that group, primary spontaneous pneumothorax 5, and secondary pneumothorax 64. And if you look at the success in the iatrogenic, 15 of 15 were successful. In the surgical resection, 22 of 28 were successful. In the primary spontaneous pneumothorax, 1 of the 5 was successful. And the secondary spontaneous pneumothorax, 37 of 64 were successful. So overall, again, a very good success rate. However, in patients post-surgery or iatrogenic, they tend to have a higher success rate as opposed to those with primary and secondary pneumothorax. Now, here's just a summary of various different studies looking at both spiration and Zephyr for bronchopleural fistula. They are a combination of retrospective and prospective. Majority of these are small, anywhere between 10 to about 100 patients. But you can see that on the first study in 2009, 40 patients, success rate with Zephyr valve was 93%. A study in 2011, 7 patients with spiration, success rate of 75%. A study in 2003 looking at 19 patients, combination of Zephyr and spiration, 77% success rate. In 2014, 10 patients with spiration, 67% success rate. And in 2016, 112 patients, the largest study with spiration, about 56% success rate. So overall, I would say average, when you average all these studies, the average success rate is about 70 to 75%. And that's what I usually quote the patients or the fellows, is that bronchoscopic method is very safe, does have a good success rate, about 75%. So it is a good option with very low risk, because again, it is a very easy deployed, easy procedure to be done. So again, looking at the various studies, anywhere between 70 to 90%, average about 75%. It is a good option for patients with continuous air leak. And again, it is a procedure that I think, is discussed amongst groups, discussed amongst thoracic. It's good to have this multidisciplinary approach. Now, just in the last few minutes before wrapping up, I want to describe a little bit about what we've done in some of our more complex patients. We've done this procedure where I do a combined bronchoscopy and pleuroscopy at the same time. So what I'll usually do is insert with the pleuroscope first. At that point, intubate the patient, go under general anesthesia, and insert from the bronchoscope from the mouth. So now we have one person looking from the pleuroscope side and one person from the bronchoscopic side. Now the idea is I do the opposite of the methylene blue. So instead of injecting the methylene blue in the pleural space, what I do is inject the methylene blue bronchoscopically in various different segments of where I think the damage is. And what I'm doing via the pleuroscope is I'm looking for that dye to be visualized in the pleural space. And so what I usually will do is give the patient about few cc's of methylene blue, follow it with some normal saline, and then you have to give it about 30 seconds to a minute before you can observe it on the other side in the pleural space. Once that's happened, I identify where the leak is, and I'm able to place valves bronchoscopically during the same procedure, as well as do targeted blood patch therapy in where I think my damage is, place a chest tube, again, in that area that I would like under direct visualization, and then come out. And so now the patient has a valve as well as a pleurodesis combined procedure, targeting an area that I know the damage is really coming from. And so here's just a picture from the pleuroscope side. You can see the methylene blue. I instilled it from the bronchoscope side, and then our fellow here, Rodrigo, was visualizing it from the pleural side, and you see the blue discoloration. Hence, we were able to identify where the lesion is and deploy valves endobronchially, and then do blood patch pleurodesis from the bronchoscope side, pleuroscope side. Here's our 7-patient experience that I've had. These were kind of very end stage patients, so they Most of them were transfer ins. Most of them had everything tried. Some of them had pleurodesis tried, blood patch tried, prolonged chest tube. And so you can see older age population, 60 to 70, majority of them have lung disease, COPD or ILD. And so you can see that the air leak before ranged anywhere between 1 to 3 months. I mean, again, a lot of these patients were at outside hospitals for weeks, and then they would come into the hospital. We would try various options. So this was kind of as a last ditch effort. All 7 of them had 100% resolution. Average time was about 7 days before the chest tube was removed, and all of them were subsequently discharged within 2 weeks from the hospital. Most of them I have followed up in my clinic and have had no mortality or any issues with the procedure whatsoever. And so that's just a novel method. Hopefully we'll have more numbers in the future to see if that method really does work, but again, something to consider. So as a conclusion, again, BP alveolar pleural fistulas can be a challenge to treat. Again, supportive care is important. Make sure they have high nutritional status, treat infections, decrease positive pressure, as well as suction on chest tube. If it is post-surgery, again, early surgical treatment is the treatment of choice. However, in patients who are non-surgical patients or other causes, large fistulas, you can consider stents or Amplatzer devices. Those are the 2 that have been more heavily studied. Smaller fistulas can be treated with fibrin glue coils coagulation. In patients who still do have alveolar pleural fistulas that can't be visualized bronchoscopically, valves are a great choice with success rates as 70 to 90%, average in the mid 70 to 80%, with very low bad outcomes. Pleurodesis, both with talc or blood, is a great option. Blood is very safe with a high success rate reported as high as 90%, however, may need to be repeated. Again, overall, I think there's a lot more research on this topic that is needed and much more guidelines that are needed to come. But again, this is a quick overview of all the, hopefully, treatment modalities for bronchopleural fistula. Happy to take any questions, any anecdotes, people's different experiences. Always interesting to hear what other people's experiences are.
Well, thank you so much, Reza. This is a very comprehensive review. This is a behemoth of a lecture. I think there has been a lot of clinical information and review of the current literature. I have a first question here. Talks about, I know you have talked about grading, but does quantifying the volume leaked makes a difference in the management?
I think so. Just like some of the studies suggested, I think both anecdotal and my experience, I think the larger the leak that you have, the more treatment failure and the less the kind of supportive and conservative managements are not likely to work. So I think if someone who has a very small, maybe grade 1 leak, conservative management with just chest tube or maybe considering blood patch is likely to work. However, those who may have a large, grade 4 leak throughout the respiratory cycle, they probably are not going to do well with conservative management. And as we saw with whether it's pleurodesis or blood patch, the larger the leak, the more likely it is that you will have treatment failure. And so I think it does kind of suggest to possible treatment failure depending on the size and scale of the leak.
Okay, excellent. Another question is in regards for chemical pleurodesis, does it have any risk of developing pneumonitis, considering that there's an existing communicating fistula? I know you talked about ARDS, and I know that's a well-known risk factor from the past, considering all the agents that are used. But do you think because this is a pleurodesis for fistula, there's an increased risk for pneumonitis? And I know that's an area of interest of you, drug-induced pneumonitis. So.
Yeah, no, very, very actually interesting. And I've heard that topic not only brought up, but that discussion, had. my experience, we've done probably now over 50 or so pleurodesis for various different bronchopleural fistula reasons. And the risk of developing ARDS and pneumonitis in alveolar pleural fistula is extremely small. I would say, and again, in my experience, almost near 0%. However, if you do have a large bronchopleural fistula, so the large fistulas that you can visualize bronchoscopically, or a large opening, I probably would be hesitant to treat those with talc or iodine or any sclerosing agent because of a higher risk of, going into the lung parenchyma and causing damage. But for the alveolar pleural fistulas, because I think the opening is really small, that by the chance that you have for that sclerosing agent to enter the lung parenchyma, you probably will have pleurodesis already happening. And so I think the risk is very small in alveolar pleural fistula. But for bronchopleural fistulas or large fistulas, I would be a little cautious.
Okay, awesome. And last question is mine. And I know you mentioned the 6 weeks time from placement of endobronchial valve. Has that been your practice, or do you kind of look at it case by case, or what's been your experience?
So I do really believe it's a case by case, and I know the recommendation is 6 weeks because, well, it is a foreign object, increased risk of developing infections and so forth. However, I do really think it's a case by case, and I'll use an example. So there is a patient that took a really long time and various different kind of staged approaches to endobronchial valve. So we first took out segments of the right upper, then the entire right upper, then had to involve the right middle and even the superior segment. So that patient then came to see me in clinic 6 to 7 weeks later. However, because when she had the bronchopleural fistula, she was in a very debilitated state. She was, almost, in the hospital, going to die. In that patient, we decided we're going to actually leave this in for 12 months. And she saw me later and is doing well, no issues. So I think if it was a very small leak, patient was clinically stable, I think that 6-week guideline does follow through. However, if the patient was very clinically sick, especially some of the COPD pre-transplant patients, going beyond that 6 weeks is not unreasonable. And I know several of my colleagues have tried it too with very low bad outcome. So it is really a case by case basis, but a very good question there.
Thank you. And last question, is there anybody concerned about, is there any description in the literature about pleurodesis with talc causing further cancer development as it is associated in other organs?
Yeah, so that's a very common question I get asked with patients who we do talc pleurodesis. Obviously, a lot of these are for malignancy, so they already have cancer, and well, the life expectancy once the cancer is in the pleural space is not long enough for us to know. And so as of yet, for at least pleurodesis, we do know there's a lot of correlation between talc and other cancers. But as of now, we do not have any evidence to suggest that using talc for pleurodesis leads to an increase in any form of cancer related to that talc. But I think a very interesting question and a topic that does really need to be addressed, especially in young patients who may have pneumothorax and you may be considering pleurodesis. I would be really cautious because of that risk, and we just don't have enough data or enough patients to be able to answer that question appropriately.
Okay, well, awesome. We have a last minute questions. Thanks for your excellent presentation. What about spigot or spigot in case of fistula? I'm not really familiar with this device, or it's spelled as an SPIGOT. I'm not sure if you're familiar with it.
Spigot. I personally am not, so I don't know too much about that device. I personally haven't used it. I don't know if anybody else on the call has, but I haven't.
Yeah, first time I heard it, but I guess we could always discuss this via email. So thank you, everyone, and I appreciate it, Reza, for coming on tonight. And until another webinar.
Yeah, thank you so much. Thanks for having me. It's been a pleasure.
Take care. Bye.